All right, let's jump right into this explainer. We're going to unpack the critical, high-stakes clinical protocol for managing a patient in shock. You see, when a life is on the line, medical professionals absolutely do not rely on guesswork. They use a highly structured, battle-tested system. So today, we're going to walk through that exact framework together and translate some pretty complex emergency medicine into a clear, methodical roadmap.
Here's the clinical sequence we'll be following today. We'll start by defining the shock syndrome, then move into Step 1, rapid assessment, Step 2, airway management, Step 3, fluid resuscitation, Step 4, targeted medications, and finally, Step 5, definitive treatment.
Let's kick things off with defining the shock syndrome. Now, the really crucial thing to understand here is that shock isn't just a basic symptom, like a cough or a fever. It is a highly dangerous, system-wide syndrome. It's triggered by a critical drop in effective circulating blood volume or fluid in the body, usually as a result of an injury or illness. When that fluid drops, your entire system goes on red alert. Everything we cover in the next few steps is literally aimed at reversing this specific, massive deficit. Moving right along to Step 1, rapid assessment. When a patient comes in, we've got to immediately check diagnostic tests and look for some very dangerous thresholds. Specifically, you're looking for a systolic blood pressure plummeting under 90 and a heart rate, which we call tachycardia, exceeding 100 beats per minute. You'll also notice rapid respiration. But hey, it's not just about the monitors. We also look closely for physical symptoms like oliguria, which is a decrease in urine output because the body is desperately trying to hoard fluid. We'll also see an altered mental status, simply because the brain isn't getting the volume it needs to function clearly. And this brings us to a vital contrast that can completely change your treatment path. While most shock patients will actually feel cold and clammy to the touch, since their blood is retreating from the skin to protect vital organs, you have to be on high alert for the exceptions. Septic or anaphylactic shock actually present with warm, flushed skin. Recognizing this difference instantly during your rapid assessment helps point you toward the correct underlying cause right out of the gate. It's a total game changer. Which brings us to Step 2, airway management. So we start by checking blood oxygen levels, the SpO2, and providing supplemental oxygen via a mask or cannula. But we don't just set it and forget it, right? We have to recheck. If that SpO2 level drops, we escalate by placing an endotracheal tube. And in those terrifying moments where an endotracheal tube just isn't possible, we bypass it immediately. We'll insert a supraglottic airway device, or if absolutely necessary, perform a surgical cricothyrotomy. Bottom line, the airway must be secured no matter what.
Next up is Step 3, fluid resuscitation. Now, you can't just pump any fluid into any patient. We rely on isotonic solutions like normal saline or Ringer's lactate for hypovolemic shock. But if it's distributive shock, we escalate to crystalloid solutions combined with a vasopressor to help tighten up those blood vessels. But listen, there is a massive warning here. As we push these fluids, we absolutely must monitor urine output and lab values to avoid a catastrophic fluid overload. If we push too much too fast, we can actually cause secondary complications like pulmonary edema, where fluid starts backing up into the lungs. So it's a very delicate, high-wire balancing act for sure.
All right, Step 4, targeted medications. At this stage, our medication strategy is entirely dictated by the specific type of shock. We aren't just treating symptoms anymore. We're targeting the actual mechanism. For hypovolemic shock, we stick with those crystalloid solutions. But consider cardiogenic shock. For this, we need inotropic drugs, like dobutamine, which specifically increase cardiac contractility to get the heart pumping effectively again. For septic shock, we need a crystalloid, a vasopressor like norepinephrine, and, critically, antibiotics. And for an allergic response like anaphylactic shock, we deploy a really powerful trio. Epinephrine, injected intramuscularly as the first line, followed by a corticosteroid like prednisolone and an antihistamine like diphenhydramine. Finally, we reach Step 5, definitive treatment. The golden rule of this entire protocol, the absolute pinnacle of definitive treatment, is that you must first accurately assess the type of shock so you can neutralize its specific root cause, because if you don't stop the cause, the syndrome is just going to keep returning. Let's break down how we actually neutralize those causes. For hypovolemic, cardiogenic, and obstructive shocks, the focus is largely mechanical. For instance, with hypovolemic shock, we literally have to stop the bleeding, provide fluid or blood transfusions, and often take the patient straight to surgery. For cardiogenic shock, we have to mechanically restore blood flow to the affected area of the heart using specific medications or surgeries, like an angioplasty. And for obstructive shock, we clear the physical blockages using thrombolysis. Those are your clot-busting drugs, followed by catheter-based angioplasty or other surgical interventions. Conversely, for distributive shocks, the whole approach shifts. Instead of structural plumbing issues, we have to attack the biological triggers. For septic shock, the definitive treatment is aggressively treating the underlying infection that's poisoning the system. And for anaphylactic shock, the definitive cure is removing the offending allergen entirely and maintaining those protective medications we discussed just a minute ago.
As we wrap up this explainer, I want you to consider this. If identifying the underlying cause is the master key to unlocking definitive treatment, how can mastering these 5 interconnected steps train us to see past the immediate, chaotic symptoms of a medical emergency? Next time you're faced with a crisis, don't just look at the symptoms. Look for the system.